Menstrual health. Everything you were never taught. Every month. Same pain. Same shame. Same silence. It ends here. Every month, something happens to half the world's population. And every month, most of them navigate it alone, without accurate information, without adequate support, and often without being believed when something is wrong. This is the menstrual health conversation that should have happened years ago. Let's have it now. Here is where we start. Each month, approximately 1.9 billion people worldwide experience menstruation. That is roughly a quarter of the entire human population, every single month, going through a biological process that affects their health, their energy, their mood, their productivity, and their quality of life. And yet, fewer than 2 in 5 schools globally provide any menstrual health education at all. 500 million people who menstruate daily do not have adequate access to menstrual products, clean sanitation, or proper health information. This is not a minor gap. This is a global public health crisis, wearing the face of a topic people are still too uncomfortable to say out loud. In the next 11 minutes, we are naming everything. What a healthy menstrual cycle looks like, what warning signs should never be ignored, the most common disorders that go undiagnosed for years, the myths doing active harm, the treatment options that genuinely work, and what all of us can do to close the gap. No shame, no whispers, just clarity. Section 1. What is a normal menstrual cycle? Before we talk about what goes wrong, let's establish what normal actually looks like. Because one of the biggest problems in menstrual health is that most people were never taught the baseline, which means they cannot recognize when something has shifted. A typical menstrual cycle runs 21 to 35 days, measured from the first day of one period to the first day of the next. On average, a person menstruates from age 13 to 51, about 38 years, with a period occurring roughly every 28 days lasting 3 to 7 days. That adds up to approximately 456 periods in a lifetime. The cycle has 4 phases. The menstrual phase, days 1 to 5 on average. The uterine lining sheds. Blood flow is normal. Some cramping is common. The follicular phase, days 1 to 13. Estrogen rises, the uterine lining rebuilds, and follicles in the ovary prepare to release an egg. Ovulation, around day 14. A single egg is released. This is the window of peak fertility. The luteal phase, days 15 to 28. Progesterone rises to prepare the uterus for a potential pregnancy. If no fertilization occurs, levels drop, triggering the next period. What normal blood flow looks like. Typical blood loss per cycle ranges from 30 to 80 milliliters, roughly 2 to 6 tablespoons. A period requiring more than 1 pad or tampon per hour for several consecutive hours, or lasting beyond 7 days, is clinically considered heavy and warrants evaluation. Normal discomfort versus abnormal pain. Mild cramping in the first 1 to 2 days is common. Pain so severe that it disrupts school, work, or daily function is not normal, and it is not something to endure silently. Quick check-in. How many of these cycle basics were you taught in school? Drop your honest answer in the comments. Section 2. Common menstrual disorders. What the symptoms actually mean. Now let's talk about the conditions that are affecting millions of people monthly, and going undiagnosed, dismissed, or minimized for years. Dysmenorrhea, painful periods. Dysmenorrhea is the most common menstrual disorder globally. It comes in 2 forms: primary dysmenorrhea, painful periods with no underlying condition, and secondary dysmenorrhea, pain caused by an underlying reproductive condition such as endometriosis or fibroids. The pain is not mild discomfort. For many people, it is waves of cramping that radiate into the lower back and thighs, accompanied by nausea, diarrhea, and vomiting, severe enough to make standing upright impossible. A 2025 study found that heavy, prolonged periods and severe menstrual pain are directly associated with lower school attendance rates and poorer academic exam scores. This is not weakness. This is a physiological disorder with a biochemical cause, prostaglandin overproduction driving intense uterine contractions, and it responds to treatment. Menorrhagia, heavy menstrual bleeding. Menorrhagia involves excessively heavy or prolonged bleeding, more than 7 days or blood loss beyond 80 milliliters per cycle. The lived experience. Soaking through a pad or tampon in under an hour, passing clots larger than a 50-cent coin, canceling plans because you cannot leave the bathroom. Many people with menorrhagia also develop iron deficiency anemia, chronic fatigue, dizziness, and shortness of breath that compound the physical toll. Heavy bleeding can signal underlying conditions including fibroids, polyps, adenomyosis, bleeding disorders, or thyroid dysfunction, all of which are diagnosable and treatable. PMS and PMDD. Up to 80% of menstruating people experience at least one physical or psychological symptom during the luteal phase, the 2 weeks before their period. This is PMS, premenstrual syndrome, and for most, symptoms are manageable. But for 3 to 8% of menstruating people, the experience is categorically different. PMDD, premenstrual dysphoric disorder, is a severe, often disabling condition involving profound mood disturbances, extreme irritability, depression, anxiety, and physical symptoms that significantly impair daily functioning. PMDD requires at least 5 symptoms in the luteal phase, including at least one mood symptom, that disappear within days of the period starting. That disappearance is the diagnostic key. It is not generalized depression. It is cyclically triggered by hormonal shifts. PMDD is a recognized medical condition in the DSM-5. It is not being too emotional. It is neurobiological, and it deserves clinical treatment, not dismissal. Amenorrhea, absent periods. Amenorrhea is the absence of menstruation, missing at least 3 consecutive periods, or not having a first period by age 15. It can be caused by extreme stress, significant weight loss, excessive exercise, thyroid disorders, elevated prolactin, or conditions like PCOS. It is not a gift or a convenience. Absent periods often signal that the body is under sufficient physiological stress that it has deprioritized reproduction entirely. The downstream effects on bone density and hormonal health are significant and long-term. Endometriosis, the silent epidemic. Endometriosis deserves its own video, but it cannot be left out of this conversation. Endometriosis affects approximately 190 million women and girls worldwide, roughly 1 in 10 of reproductive age. Average diagnosis takes 7 to 10 years. Tissue similar to the uterine lining grows outside the uterus, on ovaries, fallopian tubes, the bowel, the bladder. It bleeds monthly with no exit, causing inflammation, adhesions, and pain that can be severe and constant. The reason diagnosis takes a decade: women are told their pain is normal, that they are being dramatic, that painful periods are part of the deal. They are not. Endometriosis is a disease. It requires a diagnosis. It has treatment options. And every year it goes undiagnosed, it progresses. Pause here. How many years did it take you, or someone you know, to be believed about period pain? Because if that number is more than 1, it is already too long. Section 3. A real story. Consider this story, told in different forms by millions of people around the world. Priya was 14 when her periods began. Every month, she missed 2 days of school. Every month, her mother gave her a hot water bottle and said, "It runs in the family." At 19, she fainted from pain at university. The campus doctor prescribed ibuprofen. At 24, she was diagnosed with stage 3 endometriosis during a laparoscopy for suspected appendicitis. 10 years, 1 hot water bottle, 0 diagnosis. Her experience is not rare. It is the norm for millions of people whose pain was normalized, minimized, and medically dismissed, because menstrual pain has historically been treated as a social inconvenience rather than a clinical symptom. The system failed Priya. It is failing people like her right now. This video exists so that number gets smaller. Section 4. Myths versus facts. Now let's name the myths, because they are keeping people from getting help. Myth 1. Period pain is normal. Just push through it. Fact. Mild cramping is common. Pain severe enough to disrupt daily life, work, school, social function, is dysmenorrhea and is clinically abnormal. It is caused by prostaglandin overproduction or underlying pathology and responds to treatment. Pushing through it does not make it better. It delays diagnosis. Myth 2. Irregular periods just happen sometimes, it's nothing to worry about. Fact. Occasional variation is normal. Persistent irregularity, cycles shorter than 21 days, longer than 35, or absent for 3 or more months, is a clinical signal worth investigating. It can indicate thyroid dysfunction, PCOS, prolactin elevation, hypothalamic suppression, or perimenopause. A blood panel and clinical review take 1 appointment. Myth 3. Heavy bleeding is just how some people are. Fact. Heavy menstrual bleeding is a medically recognized condition. It can lead to iron deficiency anemia and signal underlying pathology including fibroids, adenomyosis, polyps, or bleeding disorders, all of which are diagnosable and treatable. Heavy bleeding is not a personality trait. It is a symptom. Myth 4. PMS is just moodiness. Everyone has it. Fact. PMS is real and common. PMDD is a distinct, severe, clinically recognized disorder. The difference is not degree, it is kind. PMDD causes symptoms severe enough to impair functioning, and it requires medical evaluation and treatment. Telling someone with PMDD to just track their mood is the equivalent of telling a diabetic to just eat less sugar. Myth 5. Period poverty is only a problem in developing countries. Fact. In the United States, 2 in 5 adults struggle to afford period products, and nearly 1 in 4 students faces the same barrier. In Australia, 64% of respondents in a 2024 national survey reported struggling to afford period products. Period poverty is a global reality, crossing income levels, continents, and generations. Myth 6. Talking about periods is inappropriate or embarrassing. Fact. Menstruation is a biological function that affects 1.9 billion people every month. The stigma around discussing it openly, in schools, workplaces, homes, and healthcare settings, is the single greatest barrier to early diagnosis, adequate treatment, and equitable access to care. Silence costs health. Conversation saves it. Which myth have you heard most often? Drop it below. Your answer helps me understand what content this community needs most. Section 5. Treatment options that work. Here is what evidence actually supports, because you deserve to know your options. Medical treatments. For painful periods and endometriosis, NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen and naproxen reduce prostaglandin production and are first line for dysmenorrhea when taken 1 to 2 days before the period starts, not reactively when pain is already severe. For endometriosis, hormonal suppression, surgical laparoscopy, and specialist referral form the evidence-based pathway. For heavy bleeding, tranexamic acid reduces blood loss by up to 50% without hormonal intervention. Hormonal IUDs, particularly the levonorgestrel releasing system, reduce heavy menstrual bleeding by up to 97% and are now considered first-line treatment in many guidelines. For underlying fibroids or polyps, minimally invasive surgical options exist. For PMDD, SSRIs, selective serotonin reuptake inhibitors, are the most evidence-supported pharmacological treatment for PMDD, and can be taken continuously or only during the luteal phase, the 2 weeks before the period. Hormonal suppression using GnRH analogs or combined oral contraceptives is also used in specific clinical contexts. For irregular cycles, thyroid management, prolactin normalization, PCOS treatment protocols, and in cases of hypothalamic amenorrhea, nutritional rehabilitation, stress reduction, and addressing excessive exercise, all restore cycle regularity when the root cause is identified and treated. Nutritional and lifestyle approaches. Omega-3 fatty acids, from fatty fish or supplementation, have demonstrated significant reductions in prostaglandin production and dysmenorrhea severity in multiple randomized controlled trials. Magnesium reduces cramping severity and PMS symptoms through smooth muscle relaxation and nervous system regulation. Iron-rich foods and supplementation are non-negotiable for anyone with menorrhagia who has been diagnosed with deficiency. Regular aerobic exercise reduces prostaglandin-driven cramping, stabilizes mood in the luteal phase through endorphin and serotonin pathways, and improves sleep quality throughout the cycle. Heat therapy, applied consistently to the lower abdomen, has clinical evidence for pain relief comparable to ibuprofen in mild to moderate dysmenorrhea. Simple, accessible, and effective. Tracking and advocacy. Track your cycle. A 2024 Oxford University study confirmed that menstrual tracking apps are being used in over 100 countries, and consistent cycle data is the single most useful tool you can bring to a medical appointment. Date, duration, flow, pain score, and mood each cycle. This data is what gets you taken seriously. Advocate for yourself. Ask for a specific diagnosis, not just, it's normal. Request the tests that match your symptoms. Pelvic ultrasound for fibroids or endometriosis, blood panel for thyroid, iron, prolactin, and hormones. If dismissed, seek a second opinion. You are entitled to one. Section 6, Period Poverty and What We Can Do. We cannot talk about menstrual health without talking about access. 500 million people globally lack adequate access to menstrual products, clean sanitation, or basic menstrual health education. Only 39% of schools worldwide provide adequate menstrual health facilities. 56% of respondents in a 2024 Australian national survey missed work due to their period, at an estimated economic cost of $9.6 billion annually. The consequences of period poverty are not merely inconvenient. They are documented. lower school attendance, reduced academic performance, compromised dignity, and preventable reproductive health infections from inadequate hygiene management. What can each of us do? Individually, donate to period poverty organizations in your country. Advocate for free menstrual products in schools and workplaces. Normalize the conversation so young people feel safe asking for what they need. In schools, push for menstrual health education, not just biology, but practical knowledge about normal cycles, disorders, tracking, and accessing care. In workplaces, advocate for menstrual leave policies and accessible period products. 74% of women surveyed said they would have a higher opinion of their workplace if it provided period products. This is a retention and well-being issue, not just a welfare one. The biology is universal, the access should be too. A message of clarity and power. If you are watching this and recognizing symptoms you've carried for years, pain dismissed as drama, cycles described as just how you are, moods minimized as hormonal, I want to say this to you directly. You were not wrong to notice. You were not weak to struggle. You were let down by a system that spent too long treating menstrual health as a secondary concern. Your cycle is a vital sign. When it is regular, pain-free, and predictable, that signals health. When it is disrupted, painful, heavy, or absent, that signals something that deserves a clinical response. You are entitled to that response. You are entitled to a diagnosis. You are entitled to treatment. And you are entitled to live your life every single month, not just on the weeks that aren't your period. That is what menstrual health means. And it starts with the conversation we just had. If this video said something that needed saying, like it. It tells YouTube this content matters, and it helps more people find it who need it right now. Subscribe. We cover women's health, hormonal science, and global health equity every week. Shame-free, evidence-based, for everyone. Comment below. I want to know. What is the one thing you wish you had been taught about menstrual health earlier? Your answer might be someone else's breakthrough. Share this with a teenager who is being told her pain is normal. With a friend who has been dismissed by a doctor. With a parent who wants to give their child better information than they received. With anyone who has ever felt alone in this. Because half the world menstruates. None of them should do it in the dark. See you in the next one.